Good evening and welcome to the QRME Rural Medicine Grand Rounds. I'm Dr. Lucy Ingram. Tonight we'll be exploring topics in infectious diseases. Discussing the first presentation tonight, we have our panel of experts consisting of Dr. Jim McConochie, Rural GP with QRME, Dr. Stephen Yates, SMO from Warwick, Dr. Penny Hutchinson, Public Health for the Darling Downs, West Moreton Health Service.
Darling Downs and Southwest Hospital and Health Services.
Thank you, Penny. And Dr. Antony Faa as well, SMO from Warwick. Can we please put our hands together for our panel tonight? Our presenter tonight is Dr. Hollie Berghofer, a GP registrar from Warwick. Can we all please welcome Hollie?
Hi, good evening everyone. As Lucy said, my name is Hollie Berghofer. I'm a GP registrar in Warwick. And tonight I'll be presenting two cases under the broad umbrella of infectious diseases. The first case is the returned febrile traveller, and the second case is on zoonoses. I believe we're starting with the returned febrile traveller. So the history for this patient is a 41-year-old female who presents to our hospital with a 7-day history of fevers, headache, malaise, myalgia and diarrhoea. She has no signs of infective symptoms, no urtes, no urinary symptoms, no rashes, skin infections, no sick contacts and no history of vomiting. She has recently returned from travel to Papua New Guinea to Rabaul, where she spent 13 days. She stayed there for, 13 days ago she returned. She stayed there for 10 days duration. She did not travel with any malaria prophylaxis. As past medical history, this patient has a history of childhood malaria. She takes no regular medications and she has no allergies. She is a PNG national. She was born and raised in Papua New Guinea, and she's been a resident in Australia for the last 8 years. This recent trip was a trip home to visit her family. So on the examination, she had a temperature of 38.4 degrees, heart rate of 120 beats per minute, respiratory rate of 18 beats per minute, and a blood pressure of 110/75. She's alert, there's no evidence of meningism, her GCS is 15. She has mild pallor and no jaundice or rash. There's no palpable lymphadenopathy. Heart sounds are dual with no murmur, and her chest is clear with no respiratory distress. Her abdomen is soft with a tender and large spleen. Investigations were ordered, so blood tests including cultures, chest x-ray and urine MCS, so our standard septic screen. Our differential diagnoses for this febrile traveller are malaria, dengue and Japanese encephalitis. The initial bloods came back with malaria parasites being positive, with a parasite count of 26,000, parasite density of 0.5, and the species was Falciparum. She had a normal hemoglobin and normal white cell count, but was noted to be thrombocytopenic with a platelet count of 66. Her liver function tests were deranged, predominantly her ALP, but mild enlargement of the others. LDH was elevated as well. Her blood sugar was normal, renal function was normal, her electrolytes were essentially normal, and her coags were good except for that low platelet count. So the admitting doctor devised a plan that was to admit this patient to hospital, commence a 4% dextrose infusion, perform BSL's QID, and was wishing to be notified if they were less than 3. 4-hourly OBS, specifically worried about GCS, respiratory rate and SATs, and quinine was commenced, 600 milligrams 8 hourly, and doxycycline 100 milligrams twice a day for 7 days. And the plan was to repeat the blood films in a few days to ensure eradication of the parasite. She was also requiring serial ECGs. So progress. This patient felt improved after the commencement of the quinine and the doxycycline. She was noted to have fevers over the first 48 hours as an inpatient, which then settled. Her serial ECGs were normal, her BSLs were normal, and her bloods overall were improving. So she was discharged home on day 4 of admission, and the repeat blood film showed no more malarial parasites. So this here is a copy of the bloods throughout admission. She had daily FBCs and ELFTs. As you can see, her platelet count returned to normal by day 4 of admission, and her liver function started to improve. The parasite count from the 13th, which was day 3 of admission, was no parasites seen, and that stayed the same for the next few days. And that's just a summary of the first day's blood film and then day 7. And there's some questions for the panel regarding this case. So what are the differential diagnoses in this case? What is the incubation period for malaria? And this patient had malaria as a child. How has she contracted it again? What are the complications of malaria? What is the average parasite clearance time? And what are the treatment options? And are there any adverse effects of antimalarial medication?
So if we can start with the first question, I might throw it out to the panel. Sort of, what do we feel, maybe, you know, as GPs, sort of what are the differentials to a patient that presents in this way? What do you think, Jim?
Well, I think they had a slide up there talking about malaria, differential, dengue, and also JE. That's going straight to the mosquito-borne vector things from New Guinea in the north. But this lady's Australian, she's been on a flight, she's been on a holiday. You've also got to consider other things such as simple things like influenza, other viral illnesses she's been in contact. Is this really from New Guinea or isn't it? So, I mean, certainly those 3 initial ones on the slides are high on your list. They've got to be excluded first, but you've then got to consider those other things if your tests had been negative. Just, she's been a traveller, has she had a flu needle, what time of year is it? Has she been in contact? Then you've got to consider sexual history, all those other things as well, even though her tummy wasn't tender and she had nothing in the history about discharges or anything else. But I think those other things, just viral illnesses, have to be considered and other things.
Just thinking broadly.
Yeah, you've got to exclude, I mean, we've got a responsibility to exclude malaria, dengue and JE because they've got public health issues as well. We have the mosquitoes here that can spread dengue. I don't think we do with JE, but and certainly we hope not with.
What do you think, Penny?
Well, we certainly don't have the vector for malaria and Anopheles mosquito. JE, there is the vector. Culex annulirostris is the most common vector for JE. In Australia, we've only really had JE up in the Torres Strait and the tip of Cape York. So it's not...
it doesn't extend much further south?
No, it doesn't tend to extend further south at all.
Great. Is there anything else that you think would sort of spark on your list of differentials of weird and wonderfuls in a case like this? Or
I mean, with the, deranged LFTs, you often think about something like hepatitis, but somebody who's grown up in Papua New Guinea, certainly for hepatitis A, you would have expected that they possibly were exposed as a child.
She's in a time frame and she's going to eat the local foods which she hasn't eaten for 8 years as well, so she's at risk of all those foodborne illnesses.
Foodborne illnesses.
I mean, for the bacterial ones, she's out of range for the 13 days, I think, but she's hepatitis A, she still is, isn't she?
Oh yes,
yeah,
yes,
21
definitely
days,
Hep A.
Alrighty, and if we can skip down then to the question about having malaria as a child and then having a recurrent infection. So what do you think, Stephen, about that?
So having had malaria presumably recurrently as a child, She probably developed a degree of partial immunity. If you survive the first attack of falciparum malaria, there is a partial immune response, but you tend to lose it if you're away, if you're not getting continuous re-exposure to the parasite. She'd been away for 8 years, so she was effectively non-immune when she returned to Rabaul. And she probably didn't appreciate that. I think people that often go back to visit family and friends often don't take into account those risks. You know, they don't think to take prophylaxis. And they're often staying in accommodation that's probably not as effectively screened from the mosquito as, say, would most tourists stay in.
And what about the different strains of malaria? Is there any cross-protection? I don't know if you can answer or Penny can answer.
I think with the different parasites, yes, you may get immunity to one, but you're not necessarily immune to all of them. But certainly with that repeat, when you certainly live in a malaria endemic country, there's that ongoing exposure to the parasites, and that sort of sustains some immunity. And it's very common, we see this with people who've come from other countries, lived in Australia. They've come from endemic areas where there's malaria and come to Australia and, yes, gone back and then become infected with malaria again. And I think the point with, certainly we see it with people travelling overseas, particularly those who go to visit friends or relatives, are often the group that are more at risks of being affected by these diseases, so things like malaria, dengue, a lot of those mosquito-borne diseases, also food-borne diseases as well, and particularly if they take their children who may have been born in Australia and take them back to a country that's a developing country, and the children become more likely to be exposed to things like hepatitis A. And it's often, they don't believe that they're at risk because they're going to see friends and relatives. And as mentioned, that they may stay places where are not appropriately screened. They're eating food that is prepared at home, which may not be the most hygienic way of preparing food. So that this particular group are at risk of these diseases. But the other thing is they don't believe that they are at risk. So it's really an important thing to find out from people, and we're finding more and more is to ask that question about travel, if people intending to travel or recent travel.
So what do you think from a GP perspective we can do to try and educate our patients or get the message out there on the GP level for these people visiting relatives overseas?
Well, it's very hard. I mean, often your advice is in conflict with their parents or their aunties or uncles are telling them. I mean, we have this problem with 2 female boarding schools in Toowoomba, close to our practice, and some New Guinea nationals that come and go quite often. There is no way we're going to get those girls to take prophylaxis for a 2-week September holiday. But if they take friends with them, that's very different. And so we get those occasionally, and we just give the same standard advice we give, try to avoid the bite initially, and that if they take prophylaxis for short stays, they're still at risk of drug-resistant malaria. And so to be sensible, both on the return and before they go, we encourage vaccinations, not just for things such as typhoid, but also for influenza, which is often forgotten. And then often, with those girls in particular, they're at an age where sexual activity, all the standard travel advice we give to them and their parents, but I guess the hardest group is that teenage group that are technically not of an age of consent, that you've got to sometimes give them the advice, and their parents look at you strange as if, why would you say that? But it's hard to get the message across.
And Penny, from a population health perspective, how do we get the message out there for travellers?
Well, I think one thing that's become quite useful is the Smart Traveller website, and referring people to the Smart Traveller website. That often gives some good travel advice. It's often up to date, and we're certainly trying to use that more and more. But also, you know, working with the travel doctors and GPs and raising the awareness with our GPs as well, as that it's really important with getting a travel history from people, and if they are planning on travelling, and just even, you know, raising that as a routine question in a consultation can reveal quite a lot of information.
Great. So, Antony, what can you tell us about malaria? There's a question there about sort of the incubation period, the complications and things like that, but have you had much to do with malaria treatment?
Oh, not for a long time, so I wouldn't probably be able to... I think the incubation period is 2 to 4 weeks, correct me if I'm wrong.
For falciparum.
Yeah, for falciparum. Depending, I mean, falciparum's the one that we worry about because it's the strain of malaria that can kill people. And the most worrying form of falciparum is cerebral malaria, so people can certainly come in with decreased level of consciousness right down to being comatosed. And but the good thing about it is that if you can diagnose it and treat it quickly enough, they can actually make almost a full recovery. It's quite amazing to see it happen like that. So I guess that's the most worrying complication. I mean, I think it can cause just overwhelming sort of multi-organ failure, can cause so-called black water fever where you get renal impairment. So it can present in a wide variety of ways.
Yeah, and if a patient presents, you know, out at Warwick, as this one did, sort of with this kind of illness, sort of how do you feel about managing that in the rural context?
I think it depends on how much experience you've had with malaria. Like if you've never seen a case, you'd be pretty uncomfortable managing it yourself. But if you'd worked in a tropical, in New Guinea or one of the other tropical countries where you've managed malaria before, you probably would be confident. So, I mean, the drugs that are used are changing all the time and getting better. I mean, we used to use quinine, you know, intravenously or intramuscularly as the gold standard of treatment, which was very effective, but it was a pretty horrible drug to take. I mean, as it caused hypoglycemia, that's why this patient was on IV dextrose and having their blood sugars monitored. But yeah, I think it comes down to experience. I think these days, I think even if you had experience, you'd always get a second opinion from an infectious disease physician these days, just to make sure that you're covering yourself. And yeah.
And Stephen, you've had some experience more recently overseas, isn't it, with malaria? If you can talk through, a bit more about the treatment that was given and sort of why. So we've touched on some of it.
Yeah, well, the use of quinine now has pretty well been superseded by the use of the artemether-based therapies. That's now the first line of therapy for falciparum malaria. And and I happened to be looking after that patient, and the reason why we didn't use a artemether-based therapy was because we didn't have one. And we rang around the pharmacies in town, and I actually consulted with an infectious diseases physician, and we decided that we would treat with what we had available, which was quinine with doxycycline. But we just had to ensure clearance of the parasite by repeating the blood film. But nowadays, the mainstay of therapy for falciparum malaria is a artemether combination therapy. So artemether in combination with another antimalarial like lumefantrine. So then now there's these commercially available drug combinations. They're available everywhere. So that's what we use, because currently that's the they're the drugs that the parasite is still sensitive to.
And I was going to say the combination is because of the resistance, is that right?
Yes, yeah, to prevent resistance. Yeah.
And is the falciparum the one that tends to be more resistant? Is that one of the strains that tends to be more resistant, or can it be any strain that?
I think any strain where there's been overuse of a particular antimalarial, you will start to get resistant strains. And certain parts of the world, we know that even the artemisinins are, there's resistance being developed against some of the artemisinins. So that's, that's always a concern.
Quite troubling, isn't it, when your best medication is starting to be, not working well enough.
That's why we have to be very judicious in what we use to treat.
I was going to say, Jim, it's one of the challenges of rural medicine to use what you have rather than what's best. Can you talk to that point at all? Or?
You've spoken about it well. You just, I guess, no, I'm not aware of any way you can test what bug you have for whether it's resistant without a trial of medication. So I guess if what you used didn't work, then you would either be importing that drug from probably Brisbane to Warwick, or you'd be sending the patient, one of the two. And that's always a problem in the country areas. You're not going to keep expensive drugs that expire. More commonly in Australia, things that we don't keep that expire are snake vaccines and things like that in really small rural hospitals. But these drugs, I guess, do you keep them in Warwick now?
I don't know. I'm not sure.
I would imagine.
Following a case like this?
Yes.
I think we do have them. Yeah.
Okay.
We can transport drugs pretty quickly from farms, certainly to Toowoomba, and I would imagine to Warwick, but when you start getting out further, it may be better to send the patient, I don't know.
Yeah, I think that the reason why we elected to trial that second line of drugs was because the patient had an uncomplicated case of falciparum malaria. She was lucid and orientated. She was not hypoxic. She was not severely anemic. She had none of those sort of hallmarks for a severe case of malaria, so we felt we could keep her and watch her closely, which we did.
Great. So the parasite cleared in under a week for her. Is that common? So what is the average clearance time? That was one of the questions, but is it common to see it clear up that quickly? Is that what you would expect with treatment that's effective?
I think you expect to see clearance of the parasite within a week, though really to have done the job properly we should have done a repeat film at 1 month, 28 days, because there's differing levels of drug resistance, and there are sometimes you can get recrudescence of the malarial parasite up to 1 month after. So we reviewing the case, I realised that was an error, that we should have actually rechecked her films at 28 days.
Was she a local to the Warwick area?
Yes.
Yep. Yeah. Presumably she would have represented with
Yeah,
fever, one would think.
hopefully.
Excellent. So we talked a little bit about the treatment options and some of the adverse effects. So I might just throw it open to the audience at this point. Are there any more questions about the case?
Just in terms of the management.
Hold on.
Oh, sorry. Just in terms of management, using the antimalarial plus the doxy, is that standard, or can you ever just do the antimalarial by itself?
Well, doxycycline is an antimalarial drug.
Okay.
And the reason why you use combination therapy is because it's been recognised that the malarial parasite can evolve, mutate and develop drug resistance on monotherapy. So the goal is to slow down the development of resistance. That is inevitable by using combination therapy nowadays. Yeah. So even with Artemether, it's used in combination with another antimalarial. Yeah.
And doxy's usually?
And doxy is an antimalarial drug.
And doxycycline would be well tolerated, would you say? Its side effects are minimal, or?
The side effect, I think, is nausea from it, but people like this are sick anyway. They're quite happy to take the tablet usually, and they're inside, so they're not going to get sunburnt from it. So I think they're the two biggest ones. You occasionally get people who get severe headaches from doxy, but they can also get the syncoism from quinine as well. So, I mean, if that had happened to this lady, I think you'd have been using the other drugs.
Great.
I was just wondering how you go about choosing a prophylactic drug for a patient who's going over to an area where they may be exposed to malaria.
Great. Prophylaxis. Who would like to touch on that?
Currently, I use, as a GP, I guess that falls to more GPs than anything. You find most GPs have medical software, and they're associated with, they're updated every 3 months, and they have their recommendations as to whether there's what malaria is resistant to, where the areas they're going. There are times you may need more detail. That's often with, say, nurses or people doing missionary work or volunteer work abroad. They may be going into different areas. If you're unsure of an area where they're going into, I always find the infectious diseases consultants at the PA in Royal Brisbane they even can tell you which valley they need to use what drug in the middle of Africa somewhere sometimes. So there's a lot of resort. I'm sure Penny's department may even know some of that, but if you're uncertain with the software, the majority of travellers are going to Bali or Thailand, and they're going to resorts, and they may have one day trekking on elephants in the jungle. I mean, the best advice for them is to wear long sleeves and lots of mosquito repellent. I had a problem, actually 2 days ago, I had a patient who's gets anaphylaxis to DEET, which is in all the mosquito repellents.
Right.
So I just told him to wear long sleeves, and we gave him some doxycycline. He was I forget where he was going, but mainly resorts.
I think a lot of it depends on where the person's going, and the other thing is how long they're going for. So there'll be some countries where you'll find falciparum's endemic, but there'll be other places where it might be ovale or malariae. So it all depends on where the person's travelling to, and also how long they're going, because there may be some people who are travelling for 12 months and they might be in a malaria endemic area for that period where so you would be questioning how long you could give them doxycycline, and you may look at another drug like mefloquine. So it's really important. The other thing is the person's medical history, any contraindications to some of those drugs as well. The Centre for Disease Control and Prevention has a very good website on travel and different for different destinations, and that's usually very up to date, that website, and certainly there are some other databases that are around that up to date. Another one that's very useful that I subscribe to is called ProMed, and it's an international infectious diseases. It's run by an International Society for Infectious Diseases, and it gives you global updates about all sorts of diseases all around the world, including, from here in Australia, and that's often very useful to follow up, because it will tell you about particular outbreaks that are going on at the time. Yeah.
I think if they're complex travel plans, most people who are doing that will come well in advance and will tend to go to the travel clinics. It's those people who are going tomorrow who come today, and it's not so much malaria prophylaxis is a problem then, it's all those vaccinations they should have had a month ago. And so that's the biggest problem we as GPs get with travel medicine. I think if people are complex, you either consult an authority or you send them on to a travel clinic. Because there are vaccines we can't give as well. In standard GP practice, unless you're authorised, you can't give the yellow fever vaccines, you can't get tuberculin testing. There are lots of things we can't do, and we have to refer them on anyway. Can I ask a question about treatment? I mean, this lady, and I guess it applies to some more our kids at high school who are going backwards and forwards. I had a case a few years ago. It was decided as a treatment option not to eradicate. just to treat her at that time with a bit of quinine. Her temperature came down within 24 hours, and she had a couple of days of quinine because she was going back and forth on holidays all the time. That would contribute to drug resistance, I suppose, all that sort of thing. But we used to do that a lot, and the Torres Strait used to do that a lot with the nationals coming in and out. Is that still an option today, or should we aim for eradication?
It's a tricky one. I think we need to ask an infectious diseases physician that question. I mean, no, and we all know that no drugs 100%, and we all know travellers is that they might be good for the first week and then things might go to pot, to custard after that. So, yeah, it's a tricky one, that one, yeah, and I think probably infectious diseases physician probably the best person to answer it.
One idea I have is that those people that are coming and going may well have a chronic parasitemia, because they are the ones that have been continually re-exposed and have developed a partial immunity to the parasite. That means that they can just have this ongoing parasitemia without symptoms, or they may occasionally develop febrile. That they may become unwell with malaria, but not seriously so. And I suppose the question then is, if they're unwell, what else could be going on?
What else?
Yeah. Could they have something else causing their fever?
And equally, I don't know how you feel, but could they then go on to be a reservoir in this country? Would that be a major concern?
Well, in Australia we don't have the vector, so with malaria is actually a notifiable disease in Queensland, and so we receive all the notifications, and so anybody who is positive for malaria would be followed up by the public health unit. What we're looking for is people who've acquired it locally, and that's where we can get concerned, is that can mean that the vector is now in Australia. Now, Australia used to have malaria, and it was only declared malaria-free in the 1980s, so it's only relatively recently that Australia was malaria-free. But with increased international travel, these mosquitoes can come to Australia, and if they find a suitable environment, which certainly in northern Australia is quite suitable for the Anopheles mosquito, if we start seeing it breeding there. And so that's where we get very concerned, particularly if we get a notification for malaria and the person has no travel history. And we have had occasional cases like that.
Interesting.
I've got another question. If the blood film came back showing Vivax malaria, would have you treated her any differently, or any things to consider? Because I think Vivax is the other common malaria in Papua New Guinea.
I think, to treat her acute illness, to me the combination therapy would be appropriate first-line therapy, but the other consideration with Vivax ovale and ovale is the hypnozoite stage of the parasite, where they actually go into a dormant phase in the liver, and the drugs used to treat the malarial parasite are only active on the blood stage, not on the liver stage. So there is the risk then that you can have a relapse of malaria weeks, months, or even years down the track, as these what they call hypnozoites or dormant phase parasites reactivate and start to multiply and enter the bloodstream. And so not only do you have to treat the acute illness, the parasitemia, with your first-line antimalarials, you've also got to eradicate the dormant phase of the parasite with drugs like primaquine. I'm not sure if there are any others, but primaquine is one that comes to mind. Yeah.
Very interesting. Are there any other questions from our studio audience tonight? No? And we may wrap up this fascinating case. We're now going to have a short intermission. Thank you to our expert and specialist panellists for their extremely valuable discussion. Stay with us for the next case presentation.